What's up, everyone? My name is Hunter. I'm a first-year emergency medicine resident, and today we're going to be reacting to episode 3 of the new season of the PITT. I'm still pretty new at this. Hopefully the editing is better than the last episode. Let's get into it.
Get the fuck out!
Is there a medic alert bracelet?
Get an ID on him?
Student ID. Name says Jackson Davis.
That's the start. Jackson, what's going on?
LED! Title section
Ronnie,
5.
be with us.
You, Mr.
Trauma
Davis.
one. King,
You're in a safe place.
you're okay.
Get out.
Trauma one.
Reasonableness?
Okay, Jackson.
2709.
We're gonna need you to calm down to get the taser barbs out of your neck.
You need to jump on that?
Covering calls for danger.
So we very frequently get patients that come into the emergency department that are altered and agitated, and it is often required that we use some sort of medication to kind of chemically restrain these patients because they are a risk to themselves and other people. A lot of people would probably assume, looking at this patient, that they did some sort of drugs that caused them to present like this, but there can be other reasons that people have agitation like this, and it's important that we get them under control so that we can properly evaluate and work them up to make sure that it's not something else. And if they do have a lot of illicit substances in their system, there are different antidotes and treatments we can use to both calm them down and prevent any adverse effects from those drugs or medications even.
Wait till after he's sedated.
10 of olanzapine?
That'll take 15 minutes to kick in. 5 of Geperidol, put them down at 5.
No, you can't give it without knowing his QT.
2 beats of a rhythm strip before we took off the leads.
Can't be in here. Get out.
That looks good. Go with the Geperidol.
Fuck out. Get off me. Get off.
So what they were referring to there is there's different medications that we can use. They're often from the antipsychotic classes, and droperidol, as I mentioned at the end of the last episode, is one of the medications that we commonly use to bring down people that are highly agitated. But droperidol, along with some of the other antiemetic medications like Zofran, can cause the QT interval of the cardiac rhythm to elongate, which is a serious adverse effect of these medications that can throw you into different arrhythmias, like covered in the first episode. Torsade de Pointe is one of those rhythms, and we want to be careful about administering these medications to people in these cases where we might throw them into a cardiac arrhythmia, which would cause even more problems.
Mr. Digby.
Just Digby.
Digby, why'd you wait so long to come see us?
I don't like going to doctors.
Well, that makes 2 of us. We all need help from time to time.
Now, I don't typically get political on this channel, but I think this was a very relevant statement by this patient. Oftentimes we get patients that, have a mistrust or distrust for the healthcare system based on previous experiences, and they will delay seeking care because of that. And when we end up seeing them in the emergency department, something that could have been preventable or treatable becomes a much bigger issue. And this is becoming a very common thing in today's political climate, where we have a lot of patients that are afraid to leave their homes even to seek medical care. And we are dealing with a lot of the kind of falling out of these adverse health conditions because of it. And it's something that needs to be talked about and needs to be addressed, because it's only making the health of our country worse and our jobs more difficult as we're seeing more and more sick patients.
Kid threw a fucking chair at me.
Work-related injury gets a full exam. Jesse here will take you.
No, I'm gonna stay here till the cops come so I can give my statement and so I can watch him.
Here.
Trust me. You do.
Kind of an interesting play. I mean, we commonly see patients that come in custody of police. But in this case, this is a security guard that was potentially assaulted by this patient, and his request to stay there and keep an eye on that patient would not really fly in most departments because of HIPAA and confidentiality. That security officer has no right to be involved in the care of this patient. So he should be able to have the curtains drawn in his room and be out of sight of this security officer, because even though there might be some sort of legal proceedings if the officer wants to press charges, the patient still deserves a right to confidentiality regarding his medical treatment.
Pull up at 90 degrees. Harder?
Yep, harder.
Do we suture those?
Nope, just a Band-Aid.
Mel, we need orders.
Right.
I got a rainbow.
CBC, CMP.
Anytime that we have a puncture wound, it's often best not to close it, especially when it comes to like bites of sorts. They can get contaminated and infected really easily. So sometimes we will wash them out, especially if they are bites. We will try to, wash them out with some saline, but we don't close them because it'll just create a pocket for an infection to form, and it's best to just leave it open and let it drain. And especially a tiny barb like that, there's nothing really to close anyway.
We're at the hospital now, Mark. What's wrong with him? Why isn't he talking?
His wife, Nancy, front seat passenger declined transport.
Fine. We weren't going all that fast. The motorcycle ran the light.
I'm Dr. Robbie. This is Dr. Alashimi.
Nice to meet you.
And this is Nurse Dana. She's our charge nurse. We need to look over your husband.
Helen, let's step over here for a minute and let him get to work, okay? Antoine, Larry, transfer out here. T1 will be open in a sec.
That was perfect transfer of communication from Dr. Robbie telling everyone what was going on, and then having Dana take the wife aside. Oftentimes we want to keep family members informed of what's going on with their loved ones, but sometimes when they are right up next to the patient or too emotional, it can actually get in the way of care for that patient. So assigning someone from the team to accompany the family of the patient can be super helpful to both keep the family informed of everything that's going on and what they are going to be doing for their loved one, but also to keep them out of the way so that the proper care can be given to the patient.
Open skull fracture, tubed in for agonal respirations. BP60 palp initially started a liter of NS, but lost his pulse en route.
Oh boy, this doesn't look good.
So this is what would be considered a traumatic cardiac arrest. There are medical reasons, and many of them, that somebody's heart would stop, but somebody's heart stops in trauma when it loses too much blood, and this is always a very bad sign. That is very uncommon for us to get patients back when this happens, and it's usually takes some heroic measures like opening the chest as we saw in the first episode. So I wouldn't be surprised if that happens with this patient and if they are lost because of it.
Joy, check his pupils. Somebody hand me a pair of scissors.
$8mm, non-reactive.
AKA blown pupils fixed and dilated. Oh,
Push skull with.
So right there, they did a pupil exam to check for how large the pupils are, as well as if they're reactive to light. These pupils were both 8mm and non-reactive, suggesting that the brain is starting to herniate out of the bottom of the skull and lose some of the reflexes that you would typically have, even if you were unconscious.
No helmet?
Nope, because he took the PennDOT motorcycle safety course.
Isn't that what you took, Robbie?
all compressions, yes, but I still wear a helmet. Is he a donor?
Also, no.
He just lied. He doesn't wear his helmet.
I think we are done here.
Intubate? Maybe, maybe not.
Mr. Yee. Joy, start a rub on his chest like this, really hard, please. Mr. Yee.
Spontaneous eye movement, response to pain, GCS is 10, borderline for intubation. No muscle tone?
What they just referred to there is the Glasgow coma scale. I'll see if I can put it up on the screen here, but it is the way that we evaluate the mental status of any trauma patient that comes in, and it refers to the patient's ability to move their extremities, open their eyes, and then voice is like whether they can speak words, answer questions, that sort of thing. And based on that scale, in trauma, it is typically more advantageous to intubate people when they have a GCS of less than 8. So we are assessing GCS on the scene as soon as they get into the department, as well as during their stay in the department, because if their GCS starts to decline, that would be a reason to intubate and take over kind of some of their body physiology for them.
Flaccid paralysis in the left arm.
Same on the right.
And both legs.
Add towels to both sides of the collar for more stability. Let's not make this worse.
Hand scan with 3D reconstruction of the spine.
He's quadriplegic?
If so, it's a low cervical injury.
Why is that, Joy? C3, 4, and 5 helps you breathe to stay alive.
Dr. Robbie said C3, 4, 5, that's what keeps you breathing and alive or something like that. What he was referring to is that the cervical nerves that come out between the cervical vertebrae 3, 4, and 5 all contribute to what is called the phrenic nerve, and the phrenic nerve controls your diaphragm and allows you to breathe. And so if you had a cervical injury above 5, 4, 3, it would cause you to not be able to breathe on your own. But because this patient was and still had deficits in all 4 extremities, they're saying that he had an injury lower than 5 because he's breathing on his own, but high enough that it would affect all of his extremities.
Got CT results for Mr. Williams.
Oh, wow. Okay.
Mr. Williams was our confused patient from the previous episodes. He had some wrist pain and then maybe some knee pain, and we were concerned about some sort of intracranial injury due to his fall.
I'm sure you have some questions. I know it's a lot to take in.
It's a tumor. It's a brain tumor.
Well, it's a mass. About 4 centimeters in the frontal lobe.
Is it cancer?
We can't say for sure right now. It could be many things. Infection, inflammation, a benign cyst.
Is it what made me fall?
Yeah, possibly.
This is another thing that we have to do as ER doctors very commonly, is that we will be the first ones to find some of these more critical findings in patients, and then we are tasked with explaining to them that they have something, but also that they're going to have to meet some specialists to figure out exactly what it is. And they often have a lot of questions, like understandably so, but that we can't answer because we don't know exactly what it is or how they're going to be treated for it. I mean, we might have a general idea, but those answers are best left to the specialists that are actually going to be treating them. So these conversations are always difficult, which is one reason that we practice doing them during residency.
Pulse ox holding steady at 99. Good tidal volume.
How you doing there, Mr. Yee?
Scanner can take him now.
I'll check the results from upstairs. Why is he so altered?
Could be concussion, maybe a small intracranial hemorrhage.
All will be revealed by the donut of truth.
Need a portable monitor? Joy, stay.
The donut of truth is referring to a CT scan. It's a very common joke within emergency medicine or about emergency medicine is that everyone gets a CT scan or a trip to the donut of truth.
So you bandaged the burn yourself?
Oh, no.
Ma'am, you're making it difficult for me to see under this dressing. Is that a tablecloth?
Part of a window curtain. Cleaner than tablecloth. I'll wait for the doctor, thank you.
But may I ask how this happened?
For weeks on end, the kids with their hoochie firecrackers going all day and night.
Oh, is this a firecracker burn?
No, sweetie, this is from the full samovar I drop on the floor when the firecrackers started going on again.
I'm sorry, what's a samovar?
It is a big metal urn for coffee or tea. They can get super duper hot, and I was never allowed to touch ours. Hello, Mrs. Kovalenko. My name is Dr. Michael Rabinovich. Everybody calls me Dr. Robbie.
Rabinovich, Jewish?
You guessed it. And I see that you are here today for a burn. Why don't we take a look?
Not married?
No, I'm not married.
Do you attend synagogue?
Not for a while. I mean, high holidays, mostly.
Where?
It's kind of funny how she really wasn't being cooperative with the nurse, but then as soon as Dr. Robbie comes in and they establish a a commonality or something that they can talk about, that rapport is built, and she is very trusting and allowing Dr. Rabi to do an exam. I've found this super common with patients, is like as soon as you can find something in common with them to talk to them about, it can ease some stress that they're having just being in the emergency department, and it makes your whole exam and evaluation that much easier.
Why do I gotta talk to a social worker?
Anytime a child's injured, we have some standard questions that we ask parents and caregivers.
Good, that's fine. Great. Ask me here.
Well, we noticed some bruising on Kylie's body, some old, some new on her back and legs. Any idea how she got those?
Yeah, soccer. She plays for a club team. They're, little girls, but they play like they're in the Hunger Games.
Well, I understand that you and Kylie do a fair amount of roughhousing.
What? I'm sorry, are you fucking kidding me? Where are you going with this? Are you saying that I hurt my daughter?
Mr. Connors, no.
Oh, no. Gina!
Mr. Connors?
Just, Gina!
Sir, take a breath.
Gina, what did you say to them?
Nothing. I said that you're a great dad.
Okay, what else?
That you guys like to wrestle.
Jesus
What?
Christ.
They wanted to know where all her bruises are
Who
from.
the fuck are you to talk about me and my daughter?
Who the fuck
Yeah,
am
that's
I?
what I'm asking.
Who the
Hey,
fuck
big
am
man, take one more fucking step.
Hey,
I
that's
dare you.
enough. You need to
Whoa,
calm
is
down.
that a
Everybody,
threat?
hey, everybody, back the fuck up!
Stop! Kylie's platelets are only 9,000.
What does that mean?
It's not what...
So obviously there's a lot of tension growing there, and Dana came in to save the day with this lab value that can explain a lot of things that we're seeing. So she came in and said that Kylie, the patient, her platelet value is only 9,000. And platelets are what tend to... And if she has a platelet value of 9,000, that is going to be very concerning for increased risk of bleeding, which would explain why she has so many bruises. She would bruise very easily with, we would call it thrombocytopenia.
We thought. It's probably ITP.
What the hell is ITP?
Something we can treat.
And so again there, it's hard. I mean, obviously when we have pediatric patients in the department, we want to do what's best for them. And if you are seeing this and are concerned for non-accidental trauma, you're going to do everything that you can to protect this patient. But in making that assumption, in that that's what was going on, the father was made out to be the bad guy, and now any sort of rapport that may have been able to be built between the doctor and, in this case, the patient's parent, has been severed and will be very hard to build back.
Those can't be the last words we say to each other, doctor, please.
Good news. CT looks normal. No bleeding inside the skull, C-spine, no fracture C.
He didn't break his neck?
Then why is he paralyzed?
You can have spinal injuries without radiologic abnormalities.
Sometimes it doesn't show up on CT, only on MRI.
Dr. Mohan? Are you sure? Okay. Critical potassium level 1.2. Wow.
Okay.
A lot of things to unpack here. So all of his CT imaging was reassuring, which is good. And then they were talking about how sometimes a spinal injury can't happen without showing up on a CT scan. So this would happen in the case of a whiplash injury. You can have bruising of the spinal cord that would cause some paralysis without having a fracture or severing of the spinal cord. And those things can be recovered from, and you can also have deficits down the road from them. And then what Dr. Mahan got a call about was a critical lab value, which is a potassium of 1.2, which is something that I feel like we talk about it often, but it's never truly the case. But there is a very rare condition where having a critically low potassium can cause paralysis. And that's, I'm guessing, what we're going to see here. And maybe they'll suggest that the paralysis caused some sort of the accident, or I guess we'll find out.
Extremely low potassium with generalized weakness and no cervical injury. We may be looking at
Hypokalemic periodic paralysis.
What is that?
It's a rare condition where potassium gets shifted into the cells, causing profound weakness, just like paralysis.
Will he get better?
Yes, back to normal in a few hours.
we please slowly 10 EQ. ACL.
Thank you so much. Did you hear that, Mark?
They are jumping to conclusions quite quickly. I mean, it might be just a coincidence that his potassium is this low. I would want to see the potassium normalize and see his exam before I made a statement like that to the family.
All right, Didi, hey, come on now, man.
Oh, how you doing, Devontae?
Fine.
Great. If you're fine, you go home.
Really?
Yeah.
Hey, tell him.
Me and my sister are making bracelets, and I put beads up my nose.
How many?
One on each side.
I gotta ask, why do you stick them up there? See how many will fit?
To shoot them out like rockets. But I breathed in, and they went deeper. And now it won't come out.
Did you try anything at home?
Yeah, I tried blowing in his mouth, but just got a little snot on my cheek.
Ain't for effort, Dad. Okay, we need to take a look with a little flash.
So what they're talking about there is called the mother's kiss maneuver. So oftentimes children, toddlers especially, will stick things up their nose, and if you blow into their mouth, air will come out the nose and hopefully dislodge whatever was shoved up there. But in this case, we have beads up the nose which have a hole in them, so my guess is that they are situated in a way that air can go through them and it wouldn't push him out at all. So he'll take a look and see what we're looking at. We actually have this fun tool called a CATS retractor in the emergency department, which is basically a very tiny Foley catheter that you can stick through a bead, inflate the balloon at the end, and then pull out, and it should pull the bead out with it.
So your little girl was ITP?
Go figure. Nothing like a zebra to kickstart your morning.
Well, it's better than the alternative.
True.
I think it's funny that she says, you know, nothing like a zebra to start your morning. The one thing about this show is that it brings all of the zebras from our specialty into a single shift, and where the PITT does a lot of things right as far as the care for patients and even working them up. The acuity is there, but all of these things that are in, especially the first season, it's like every single episode they saw one of these zebras for our specialty, and while we would see them throughout our career, seeing them all in one shift just isn't realistic. And this is 2 zebras with the ITP and the hypokalemic paralysis.
104/68. Good squeeze, good EF.
Spontaneous respirations. Okay, let's let
breathing on his own. Excellent sign.
Can I touch him?
Of course. Oh, shit! We need a gurney! Nancy. Mrs. Yee? Mrs. Yee. Weak carotid, shallow breaths.
Did she vasovagal from stress?
Can't assume that. Positive seatbelts. Oh, shit. Hang 2 units of Odeg on the rapid diffuser. Somebody call Garcia.
So what they just saw there is what's called a seatbelt sign, which is the bruising from where the seatbelt was covering the patient's body during the accident. And this is where, if we kind of call back to the initial presentation of this patient, they wanted to check her out and she said, no, I'm fine. But I think that it's pretty common that if we have a patient that is seriously injured in a motor vehicle collision, every patient that, or every other person that was part of that collision should be seen and evaluated fully to make sure that they are 100% okay, even if they say they are. And the seatbelt sign indicates that there's probably some sort of intra-abdominal injury, and because she passed out, I'm guessing that there's some internal bleeding that's causing her to be hypovolemic and bleeding out into her belly and now passing out.
We'll be treating her with high-dose steroids to suppress the immune system and IV immunoglobulin, which reduces the destruction of the platelets in the spleen.
Can I go home?
You're gonna have to stay in the hospital for about 3 days to make sure that the treatment is working.
Okay. Okay, so when can she get a room in the hospital?
That is an excellent question. I'm going to see if I can make that happen sooner rather than later, but it might.
That is probably the most common question I get once I tell a patient that they're going to be admitted is, how long until I get a room upstairs? And I will go put in a request for a bed immediately, but as far as when that bed becomes available, it's not up to me, and I have no idea when it will be. We are in a time where we have a lot of boarding and hospital congestion, so sometimes it's 5 minutes after I press that button, and sometimes it's 25 hours, and we really don't know. As ER providers, we don't have a knowledge of the congestion and flow of beds within the hospital, so it's a question that we can't answer even as much as we want to.
Unit 3 and 4 running in. BP 84/56, heart rate 112.
Free fluid's much bigger than before.
She's not turning the corner. OR's holding a room.
I'll let the husband know.
Why'd you guys wait so long to check her?
Good vitals in the field, no distress. She refused to sign in.
You should have convinced her.
20/20 hindsight, she was stable.
Until she wasn't.
Next time I'll use my x-ray vision goggles.
Let's get her upstairs.
So there they did a full exam, including a bedside ultrasound. We call it a fast exam, and they saw free fluid in her abdomen. So now she is on her way to the OR to do an exploratory laparotomy or XLAP to find out where the bleeding is coming from and repair it so that she doesn't bleed further.
Now, try and lift your arm, Mark.
I'm trying. Can't do it.
But you are getting stronger, and your speech is improving.
How did I lose so much potassium?
You didn't lose it. It got shifted into cells. When it comes back, you'll return to normal.
Where's Nancy?
She had an injury to her spleen right about here with some internal bleeding.
Oh, God.
She passed out from blood loss. We were able to transfuse her, and she's now on her way to surgery to repair that damage.
This is my fault. She's trying to... She booked a trip for us. For me. I fought her the whole time. I've been... Please don't... Oh my God, please don't let her die. Please.
I can assure you that she is in excellent hands.
Is this how it works?
How what works?
You think things are important? That everything's so important? And then you end up here and see.
Yeah, that is how it works. No, it's a small hole, like the size of a dime. Right, Doc?
Mm-hmm. Yeah, even smaller. It's a minor enough procedure that most patients go home the next day.
And then?
And then they'll know what it is and how to treat it. Isn't that right?
Yeah, exactly.
I'm sorry that they called you.
It's good to see that he is able to reiterate what the procedure is, kind of the risks and benefits, and what the plan is moving forward, which tells me that this patient has capacity to make medical decisions for himself. In this case, it seems that his ex-wife is pretty cordial with him and would be an okay decision maker in this case, but we can have it be the opposite, where the ex that comes into the picture because they're still listed in the chart as an emergency contact is actually someone that doesn't like the person, or just has no idea what the patient would want, and then if they have to make decisions, it can be very difficult. So it's good to see here that he can make his own medical decisions, but just kind of highlights the fact that it's really important to keep your emergency contacts up to date.
I never updated the form, I guess.
No, it's okay. They called and I was just kind of surprised.
Well, you didn't have to come.
But I did.
This makes me wonder if he started to have some attitude or mood changes because of whatever this growth in his frontal lobe is, and that's what caused their divorce, and now he's going to get treated and improve, and they're going to get back together. Because there always has to be romance in these shows.
Heard you got married? Congratulations.
Oh, never mind. She's married.
Current insulin is 0.1 units per kilo per hour. Next steps?
Once the glucose is down to 250, reduce the insulin to 0.05 units per kilo per hour.
Because you can normalize the blood sugar before you clear the ketones and you don't get hypoglycemia.
But as treatment continues, you'll have to give IV dextrose to keep the blood glucose in between 150 and 200 while the insulin drip clears the ketones.
Obviously.
So again, we have these med students that are kind of trying to compete with one another because they see each other as competitors for a spot in this residency program. And it's all great and everything to exhibit how smart you are, but in front of the patient's family is not the place to be doing this.
I'm sorry, what?
This is a cat's extractor with a tiny balloon at the end. What we're gonna do is we're gonna slip it past the bead, inflate the balloon, try to pull out the bead.
Is it painful?
No, he's numbed up.
I'd add support your woman and pack good snacks.
It's beautiful. And it turns out there's no handbook for fatherhood, so I will take all the wisdom I can. Blue bead out.
That was just a fun scene talking about fatherhood. I am a dad myself, have a 1.5-year-old named Odin. And so it's just kind of fun to see patients and providers all sharing stories and giving each other advice.
I haven't seen him in like 4 years.
I can't imagine. That must have been...
So crazy. You know, things were not good at the end. He was a really different person. Huge temper. Not like when we first got married.
I'm so sorry.
Could that mass have been there for a while and only recently got worse?
Yes.
Could it be responsible for how much he changed? You know, his moods and tempers, he was getting into fights with strangers.
It's possible.
Oh. Thank you.
I often commentate on things like this throughout every show that I watch with my wife, and she gets really annoyed for how frequently things that I say come back into the picture minutes, even an hour after I say it, and I just look at her and say, I could write the show.
Unless he's asked you to change it, would you please leave me as the emergency contact?
Yeah, absolutely.
It's fine to do, but if he asks to change it, they're gonna have to do that.
Oh, I should have left last night.
Well, that was another exciting episode. As always, I would appreciate any constructive criticism in the comments below. I am pretty new at doing these reactions, so I would appreciate any feedback, and we will catch you next week for episode 4.